So far, we were talking about the slower conduction, the conduction abnormalities. The conduction abnormalities can be faster. This kind of faster conduction occurs where normally the slowest charge propagation is going on, and that's the AV junction. In the AV junction, we do have some accessory pathways that is going to bypass the slowdown of the AV node. These syndromes are called preexcitation. Some people have accessory conduction pathways that provide a direct connection between the atria and the ventricle, thereby bypassing the AV node and the bundle of His. These accessory pathways allow atrial impulses to depolarize the ventricles earlier than usual. This condition is called preexcitation. There are several bundles. The most common one, a muscle type bundles. This is a cont bundle that is going to bypass the annulus fibrosis and connecting the atrial muscle to the ventricular muscle. And by developing the re-entry phenomenon can cause the WPW syndrome, or it's called Wolff-Parkinson-White syndrome. Similarly, however, a bundle that is going to connect the atrial muscle to the bundle of His, and this kind of fiber is called the James fiber, and that can cause by the re-entry this LGL syndrome. There are less importantly the Mannheim fibers that can be the His ventricular fibers or nodoventricular fibers or atriofascicular fibers with the AV-like conduction. Wolff-Parkinson-White syndrome. The most common type of irregular heartbeat that occurs is known as a paroxysmal supraventricular tachycardia. A hereditary bundle of the cont connects the atrial muscle to the ventricular muscle by passing the AV node. The key ECG features include widened QRS complex with slurring of the initial portion, such as the delta wave, and the PR interval usually is shortened than 0.12 seconds. When the assay makes the impulse, the atrium is activated, that's forming a P wave, and right after, when the charge getting to the AV node and the bundle of cont, through the bundle of cont immediately starting to activate the ventricular muscle, this is going to start the depolarization of the ventricle slower through the muscle. And meanwhile, through the AV node, the conduction is reaching the bundle of His and the bundle branches, and the last part of the QRS is activated through the normal conducting system. This is why we do have a shortening of the PR interval, so the PR distance is almost zero, and we do have a slowly sloping initial part of the QRS, so this way the initial part is widening and finished by a narrow QRSs. As you see here, this delta wave is very informative. As you see here in these tracings, the delta wave is started right after the P wave ended. This is why the 0.1 second is the P wave, and right after that the QRS is started. This delta wave can be a very small one, but can include the first part of the all QRS complexes. The WPW syndrome, when we do have some kind of tachycardias, is going to develop due to the re-entry phenomenon, because we are having two parallel pathways with different refractory periods. These cont bundle can be located in anywhere between the atrium and the ventricle on the right side, left side. But major, we do have two types. Type A, when the cont bundle is located on the left side, and this meaning that the delta wave is going to go toward the right side. So in V1, we do have an upward delta wave. The opposite, when the cont bundle is located on the right side, there is a QS complex in V1, for example, representing a negative or downward delta wave. As you see here in these tracings, in the PR interval is short, that can be seen very nicely in lead number 2, lead number 3, especially in the chest leads in V3, or as you are looking at here all the way down, that's lead number 2. And if you are looking at in V1, you do see this delta wave is starting upward. So this is a type A WPW. Opposite another one, when the V1 we do have a negative deflection of QS complex, that's a type B. LGS syndrome, very similarly to the WPW syndrome, however, these accessory pathways is referred as a James fiber. This is connecting the atrial muscle to the bundle of his. This is how is bypassing the AV node. These accessory pathways does not have any delta wave because the ventricular depolarization occurs through the normal ventricular conductive pathways. So this way, LGL only causing the shortening of the PR interval that is followed by a normal narrow QRS complex. So far, nobody could show anatomically this James fiber, only that is a hypothetical pathways. Today's they believe that this is some kind of uh, a type of the WPW when this cant bundle is a very small one, and this is why they cannot see the delta wave. Preexcitation syndrome. Unless tachycardia is present, WP and LGR are usually of no clinical significance. However, preexcitation, specifically WPW, can predispose the patient to various tachyarrhythmias. The most common tachyarrhythmia is the atrioventricular reentrant tachycardia, AVRT, followed by atrial fibrillation and atrial flutter. Atrial fibrillation and atrial flutter seen with WPW are extremely dangerous because the AV junction that normally is filtering out and doesn't let every charge goes to the ventricle, the cant bundle is going to conduct the charge to the ventricle, and very high rate of ventricular tachycardia can develop. Talking about this atrioventricular reentry tachycardias, or AVRT tachycardias, when we do have these two parallel pathways, one is a cant bundle and other one is the AV junction. Depending on how the ventricle is activated, we are going to talk about orthodromic AVRT tachycardias or antedromic AVRT tachycardias. Now, because of in orthodromic AVRT, because of the normal conduction to the ventricles regular, this is why, because the conduction occurs through the AV node and the bundle of cant is reuptaking the charge to the atrium, this way the QRS is narrow. In opposite, when we do have an antedromic AVRT, in this way, the cant bundle activates the ventricle and AV is going to reuptake the charge back to the atrium. And now we do have this antedromic AVRT. In this way, because the ventricle is activated through the muscle, the QRS complex is wider than normal. Looking at this graph, you can see immediately that is tachycardia with a very wide QRS complexes. It looks like as a ventricular tachycardia, but because we know that the patient does have this cant bundle, we know that the supraventricular tachycardia. To differentiate between a ventricular tachycardia and an antedromic AVRT, we can apply carotis massage. Carotis massage works only in antedromic AVRT, while is completely ineffective in ventricular tachycardias. Another one, the orthodromic AVRT, when we do have narrow QRS complexes, looks like as a supraventricular QRS complexes without having any kind of delta waves. Only one thing, when we do have the normal bits, we do have the delta wave. This is how we know that this patient does have this WPW syndrome. This is why we diagnose as the AVRT. Another type of supraventricular paroxysmal tachycardia is a atrioventricular nodal reentrant tachycardia, AVNRT. The AV node often has two input paths from the atriums. If the pathways have different conduction characteristics, then this can be the basis of the reentry cycle, AVNRT. Early bits such as the premature beat, can trigger AVNRT. This is the most common regular supraventricular tachycardias and most commonly occurs in women. As you see here, this re-entry is going to develop in these two pathways that is reaching the AV node. And paroxysm, when we do have a premature beat, and that is going to trigger this re-entry cycle, and we do have a very fast tachycardia that develops suddenly and ending suddenly. Looking at this graph, ECG tracing, we can see narrow QRSs with a rate of 180, 160, and there is no P wave, so possible that's a AVNRT or the supraventricular atrioventricular tachycardias.